Hi guys, welcome to today's discussion. So we'll get started. We have 5 questions lined up. Hopefully we can finish on time. So question number 1, all are true about Barrett's esophagus except A, intestinal metaplasia, B, seen in individuals with GERD, C, associated with alcoholic consumption, and D, increased risk of squamous cell carcinoma. Okay, so the answer here is D, increased risk of squamous cell carcinoma. So we'll get to why. So all are true about except means we are looking for what is false, right? So always when you get such a question in NEET, keep in mind that you're looking for what is false while you go through each option. So why is D the answer? So although it does increase the risk of malignancy, and although Barrett's esophagus is a pre-malignant condition, it increases the risk for adenocarcinoma and not squamous cell carcinoma. So here it says increased risk of squamous cell carcinoma. So therefore this is wrong. It actually increases risk of adenocarcinoma. Now, a few things to learn from this question, just from the answering point of view. If you look at option B and option C, and this is a NEET question, B is seen in individuals with GERD and C is associated with alcohol consumption. So you know GERD is associated with alcohol consumption. So therefore, essentially, these two options even come together. So one can't be right without the other. So at that point itself, this is ruled out, and you're really questioning between intestinal metaplasia and option D. So coming to Barrett's esophagus. So all of you will remember Barrett's esophagus from pathology and from surgery. So in this discussion, because of time constraints, we will only be discussing the pathological aspects of Barrett's esophagus. The surgical treatments and investigations we can discuss in a future session. So from the pathological point of view, what is Barrett's esophagus? Barrett's esophagus is nothing but metaplasia of the esophageal lining. So it is columnar metaplasia of esophageal lining. Columnar metaplasia, also called intestinal metaplasia. So this is also true. So this is true. This is true. Obviously this is true. Again, it is seen in GERD, and it is, since GERD is associated with alcohol consumption, option C is also true. So the answer must be option D, and it is true because option D is the answer because adenocarcinoma is what is caused. So quickly I'll just explain a little bit about Barrett's esophagus because it is a high yield topic. It is frequently asked. So what happens in case of a Barrett's esophagus is a patient with GERD has acid reflux. So what is acid reflux? Acid from the stomach goes into the esophagus, right? So in a case of GERD, when the esophageal lining is repeatedly exposed to the acidic contents of the stomach, these cells, and metaplasia is a cellular adaptation, these cells of the esophagus undergo metaplasia in response to the constant acidic exposure. So the normal squamous cells present in the esophagus lining will convert into columnar cells because of repeated acidic exposure, and that is nothing but Barrett's esophagus, also called columnar metaplasia in this case. So the squamous cells which normally line the esophagus are converted into columnar cells due to repeated acidic exposure. So GERD causes Barrett's esophagus, and Barrett's esophagus causes, or a complication of Barrett's esophagus is adenocarcinoma. So the answer here is D, adenocarcinoma. A few words about cellular adaptations because I want to bring in some concept into these discussions. So there are 5 main cellular adaptations going back to pathology. The first cellular adaptation which I want to talk about is atrophy. A-T-R-O-P-H-Y, atrophy. So in atrophy, what happens is there is a reduction in both the cell number and the cell size. So cell number and cell size reduces. Therefore, the size of the organ involved also reduces as a whole. Hypertrophy is the second cellular adaptation in which there is just increase in the cell size. So only cell size increases. Third cellular adaptation I want to talk about is hyperplasia, in which the cell number increases but there's no increase in cell size. So the number of cells increase but there's no increase in cell size. The fourth thing I want to talk about is dysplasia. Dysplasia is nothing but loss of the normal architecture of the cell. So the cell starts to look abnormal or different from what the normal cell in that region looks like. So that is dysplasia. And last one is anaplasia, which is a sure shot sign of malignancy. And what is anaplasia? Anaplasia, in the most simplest and accurate terms, is lack of differentiation of a cell. A cell doesn't differentiate and mature into its function. So these are 5 basic cellular adaptations that are very important. You should know for life and for the exams also. So all these 5 you should know. In this case, because Barrett's esophagus is a type of metaplasia, we'll just talk about metaplasia in little more detail. So metaplasia is conversion of one cell type to another. So when a cell is irritated or exposed to some toxic or noxious stimulus, over time it changes into another cell type that better adjusts to that noxious stimulus. So in case of Barrett's esophagus, the columnar cells are better equipped to handle an acidic environment than the squamous cells. So on repeated acidic exposure to the normal squamous cells of esophagus, the cells start changing and they become columnar type of cells, which are more attuned to accepting those acidic conditions. So metaplasia is a change of one type to another. So columnar metaplasia is nothing but a squamous cell becoming a columnar cell, and this is seen in Barrett's esophagus. And the opposite can be seen in your respiratory lining in the bronchus, where the normal squamous tissue, or the normal columnar tissue, so your respiratory tract is lined by columnar tissue, the normal columnar tissue gets converted into squamous tissue due to exposure to dust and smoke. And that's why chronic smokers are prone to developing malignancy, because first they have this metaplasia, so the normal columnar respiratory lining becomes squamous type due to recurrent exposure to smoke. Lastly, the microscopic change in Barrett's esophagus is presence of columnar cells in the lower esophagus lining. And gross appearance, very important, this image is frequently asked. Grossly, you will have a red velvety patch. Red velvety patch can be seen. This is this is endoscopic view. So in the lower esophagus, you will see a red velvety patch. So adenocarcinoma is a complication, and that was the answer. Let's move to the next question. A 45-year-old female presents with swelling involving both lower limbs distal to knee. On applying pressure, the indentation does not persist after release. What could it be? Okay, A. Myxedema, B. Nephrotic syndrome, C. Chronic lymphangitis, and D. Congestive cardiac failure. Pause the video. Yeah. So, firstly, 45-year-old female involving both lower limbs, and it is a non-pitting type of edema because when you press it, the indentation does not persist, which just means it's a non-pitting type of edema. So this is a very good clue, non-pitting. So let's look at the options and rule out the pitting types of edema. So myxedema is non-pitting, so let's keep that. Nephrotic syndrome is pitting, so let's remove that. Chronic lymphangitis, anything lymph-associated is non-pitting, so that is non-pitting, so we leave that there. CCF is pitting, so we're removing that. So we're left with 2 options, myxedema and chronic lymphangitis. Let's look back at the question. So it says a female and it says involving both lower limbs. So the answer is myxedema, and I'll tell you why. Chronic lymphangitis is also a non-pitting edema, but it is usually unilateral, and here it's clearly a bilateral edema. Next thing, myxedema. So we know myxedema is the answer. One more thing which pointed towards myxedema is that the patient is a female, and we know from our studies that thyroid related problems are more common in females, and myxedema is nothing but a manifestation of hypothyroidism. So what happens when there is hypothyroidism? There is deposition of myxomatous tissue all over the body, and that is called myxedema, and that is a non-pitting type of edema. A few notes for the entrance other than myxedema is there is something called pre-tibial myxedema. Pre-tibial myxedema, so you have myxedema over the shin, and that is seen in hyperthyroidism. So remember, pre-tibial myxedema is in hyperthyroidism. Myxedema in general is in hypothyroidism. That's one important point. The next important point I want to talk about with regard to this question is non-pitting edema has 4 causes. Only 4 causes of non-pitting edema. So you have to know them. So if you get a question with non-pitting edema, it has to be one of these 4. So the first one we already discussed is myxedema. It will be bilateral, usually all over the body. Second, so mixed edema was the first cause of non-pitting edema. The second cause of non-pitting edema is lymphatic obstruction. Basically, that is filariasis. So second cause of non-pitting edema is filariasis. Third thing is chronic lymphangitis. And fourth thing is post-removal or radical dissection of lymph nodes draining a certain area. So if you see, other than mixed edema, all the other three are lymph related. So lymphangitis, which is usually unilateral, filariasis, which is due to lymphatic obstruction, it's infective but due to lymphatic obstruction, and lastly post-surgical lymphedema. So you might have seen in wards or while studying, you might have read that post-radical mastectomy and post-removal of the axillary lymph nodes, patients develop upper limb edema, right? This is a frequent complication of radical mastectomy. So that's also another point for your surgery questions and breast related questions. Post-radical mastectomy, upper limb edema is a very common complication. So lymphedema of upper limb is a common complication, and this lymphedema, when it becomes long-standing, can also form or can also become a lymphangiosarcoma. And this condition in which a long-standing lymphedema becomes a lymphangiosarcoma is called Stewart-Trevis syndrome. Again, another frequently questioned topic, and that's why I'm mentioning. So lymphedema, long-standing lymphedema, when it becomes lymphangiosarcoma, process is called Stewart-Trevis syndrome. Okay, Stewart-Trevis syndrome, very common in post-radical mastectomy patients. Okay, so all non-pitting edemas were lymph related. So that's the take home from this. Let's move to the next question. Next three questions are very easy, very little to discuss. So question number 3, a 22-year-old woman complains of primary amenorrhea. She has well-developed breasts, but no pubic or axillary hair, no hirsutism. Which of the following is the most likely clinical diagnosis? Yeah, so let's discuss this. So a question like this, you always try to fit in the options into the question. You approach and try to fit in the options into the question. So I read the question. I know most importantly the patient is primary amenorrhea with well-developed breasts and very little axillary and pubic hair. Okay, so that's what I've taken home from the question. So first option is Turner syndrome. So we know Turner syndrome is 45XO and they have poorly developed breasts. So the option already has well-developed breasts. So we are ruling this out. So we are going to approach the question through the options. Stein-Leventhal syndrome. So we know Stein-Leventhal syndrome is another name for PCOD. And PCOD, how does PCOD present? With infertility, irregular periods and hirsutism. So if you look at the question, it says no hirsutism and primary amenorrhea was the main complaint. So it's not PCOD, so that's ruled out. So the next option is Kallmann syndrome. So what is Kallmann syndrome? We have to consider Kallmann syndrome because Kallmann syndrome is one of the causes of primary amenorrhea. So what is Kallmann syndrome? So Kallmann syndrome is a hypogonadotropic hypogonadism. It's a condition in which there is reduced GnRH secretion in the hypothalamus. So normally what happens is GnRH, which is the gonadotropin releasing hormone, is produced in the hypothalamus, and this GnRH then acts on the pituitary to produce FSH and LH, which then act on the ovary and cause the rest of the sexual development and puberty and whatnot. So in case of Kallmann syndrome, there is no GnRH production. So it's a hypothalamic condition. So there is no GnRH, therefore there is no gonadotropins, therefore there is delayed or absent puberty. So these patients do present with primary amenorrhea. And primary amenorrhea means they've never had a cycle in their life. So they never had menses. So definitely a differential diagnosis for primary amenorrhea is Kallmann syndrome. But Kallmann syndrome has a very, very, very classical feature. Fortunate for us, unfortunate for them. Fortunate for us because we can use this one classical feature of Kallmann syndrome to nail the answer, and that is Kallmann syndrome is associated with anosmia. So all those individuals affected by Kallmann syndrome have lack of smell. So anosmia along with delayed or absent puberty directly points to Kallmann syndrome. So in this case, there is no mention of anosmia. So it's not going to be Kallman syndrome either. And there is no well-developed breasts in Kallman syndrome either, because like I said, there is no puberty achieved. So Kallman syndrome also ruled out, but it is a frequent MCQ topic, so that's why I'm stressing on it. Anosmia plus delayed puberty equals Kallman syndrome, delayed or absent. Okay, so the last option, we have already ruled out everything, so this has to be the answer, and definitely is the answer. It is complete androgen insensitivity syndrome. So what is complete androgen insensitivity syndrome? Basically, the androgen receptors are not sensitive to the androgen hormone. So even though androgen hormones are produced, they are not sensitive, and this is a defect from the fetal stage itself. So even the external genitalia or external male genitalia wouldn't be formed in this case. So although phenotypically it's a perfect female with all the female features, in fact even more than most females because of the lack of hair, so a perfect female features will be found in this person, but karyotypically they are male. Okay, so they will be 47XY, 46XY, right? And to talk about little bit about congenital androgen insensitivity syndrome, firstly it is a female phenotype. There will be well developed breasts but no hair or sparse axillary and pubic hair. They will definitely have primary amenorrhea because they do not have the uterus or ovaries, right? Those are absent in these people. So how do you and they will have a short vagina, again because of the lack of formation of the male external genitalia. So in this case, how do you confirm? The definitive confirmation is by karyotyping to find the male karyotype. And in case of if you want to do it at the clinical stage, an ultrasound would reveal an absence of the uterus, upper two-thirds of vagina, and even the ovaries. So all your female organs will be absent in these patients. So we won't get into the detail of this. We are already short on time. We'll move to the next question. Very easy question, but a high yield topic. Triage is a very high yield topic. So you should read it. And triage has 4 colors: red, yellow, green, and black. So the question is, in triage, moribund patients are indicated by which color? A red, B black, C yellow, and D green. 5-second pause. Yeah. So the answer here is black. This was a fairly straightforward question. So why black? Black includes dead and moribund patients. And what do you mean by moribund? Patients who cannot be savaged. The extent of damage is so bad that they cannot be savaged. And a frequently questioned moribund example is a high spinal cord injury. So a patient, RTA case or in a war or wherever, if there is an individual with a high spinal cord injury, he is going to be labeled as moribund. And why? Any injury above C4, actually C3, is considered as a high spinal injury because the diaphragmatic control is lost and therefore respiration will soon be lost. So what comes under red, yellow, green? It's fairly straightforward, so I won't get into that. You can read it. There's a picture here too. Last question before we close up. A patient presents with pink pearly white papules on his skin as depicted in the image. How is the diagnosis for this condition typically made? So A, viral culture, B, skin biopsy, C, clinical appearance, and D, PCR for viral DNA. So I'll give you 5 seconds. Yeah, so this question again has 2 parts. So the first part is in identifying what this condition is. So whenever you hear the words pink pearly white papules, okay, pink pearly white wart-like lesions, the first thing that should come to your mind is molluscum contagiosum. Okay, that's a virus. So molluscum contagiosum should be the first thing that comes to your mind. And this picture is very classical and one of the frequently asked questions in dermatology and microbiology. So please look at this picture. Here you have your pink pearly white papule, okay, and you can see this pearly sort of region, and you have a central umbilication. So pink pearly white papule which looks like this with a central umbilication. The first thing that comes to your mind should be molluscum contagiosum. In fact, you should even diagnose molluscum contagiosum by just looking at this photo without even reading what's given above. So we made the diagnosis molluscum contagiosum. So the next part is, how is the diagnosis for this condition typically made? So how do we typically, and this is a previous NEET question. It's a controversial question. That's why I've included it. And the wording is important. The question is, how is it typically made? So if typically is asked, then the answer is C, clinical appearance, If the definitive is asked, it is B, skin biopsy. So in this case, the answer is C, clinical appearance. So although we can do a skin biopsy and find the classical molluscum bodies present in the cells, they are eosinophilic inclusion bodies present in infected cells. Although we can do that, routinely we do not do skin biopsies for molluscum contagiosum. And if you were a dermatologist who was asking for a skin biopsy in these cases, you wouldn't be getting a lot of patients. So typically, just based on clinical appearance, the diagnosis is made. So therefore, please remember, molluscum contagiosum is diagnosed clinically, and skin biopsy is only definitive, but all the time it's clinical. And that's also why this picture is so important, because it is diagnosed clinically, it is diagnosed just by looking at it, so the picture becomes automatically very important. So as usual, we've crossed the time a bit. Thank you so much for logging on and watching this. We'll discuss a few more MCQs in the coming days. Thank you.